What I hope to do now is to talk with you in the next 25 minutes or so about an area that relates to my clinical care and research, and welcome your conversation as we head through it, and especially at the end. My goals with this are to discuss the mechanisms and risks that our kidney transplant recipients may experience as they are being treated for cancer with immunotherapies to a greater extent, or considered for that. In addition to that, if we have time, we'll talk about the potential use of circulating tumor DNA as a diagnostic assay that may be used in these patients while treating for cancer. And finally, I want to discuss some upcoming work that I've been involved in related to a consult clinic and a bioregistry for transplant candidates and recipients with cancer. In terms of my disclosures, I had been a consultant last year for Natera and have funding going forward with the CUNY Foundation and potentially with Natera. As an overview, you may be aware of, and I've talked about in the past, how the general population, thankfully, is doing better with cancer. Unfortunately, that's not been translated with incidence or mortality in our transplant recipients, so that our kidney transplant recipients are 2 to 4-fold higher risk for cancer and are dying at a 2 times greater rate than our general population. The most common cancers that our transplant recipients experience and deal with are squamous cell carcinoma, non-Hodgkin's lymphoma, Kaposi's, kidney, lung, breast, and colorectal. The risks that they deal with are in part related to the age that one experiences cancer in general, preceding comorbidities that are also immunosuppressive, including type 1 to type 2 diabetes, end-stage kidney disease, tobacco use. Naturally, anybody who had a cancer prior to transplant is at higher risk, typically twofold risk higher for future cancer, including de novo cancer. And we know that immunosuppression has a number of direct and indirect risks for cancer, including decreasing surveillance of cancers, increasing the risk of oncogenic virus not being addressed, and finally, decreased DNA repair. There's much still to learn, including what the risks are for underrepresented minorities, and that's an area of interest to me. In the last 20 to 30 years, we've seen a great improvement in cancer incidence and, more importantly, in death in the general population, and that's especially borne out in the top 4 types of cancer. And especially for lung cancer, as you can see, it peaked in terms of mortality rate around 2000 and continues to improve. So that just in the last 2 years of monitoring, we've seen more than 2% absolute improvement in mortality from cancer deaths in the US in general. Unfortunately, that is not true in our dialysis and transplant population. Cardiovascular disease remains the single highest cause of death in both populations. But what is interesting is that over time, cardiovascular death in our transplant recipients has improved to some extent. Infections have improved to some extent, and malignancy continues to rise. And so even after this 2018 paper published from USRDS data, we've seen a continued increase in malignancy associated death, and that's assumed to be related to better management of cardiovascular disease and infection, while malignancy is often a later diagnosis after transplant. Because of the improvement in outcomes in the general population over the last 30 years, and that relates to screening as well as treatments, I asked the question with collaborators at the National Cancer Institute, Eric Engels and Greg Haber, whether we've seen the same type of change in incidence and outcomes in our kidney transplant recipients. And so we evaluated over 100,000 kidney transplant recipients between 1987 and 2016 using the Transplant Cancer Match Study, which reflects about 40% of all kidney transplant recipients. And we asked whether incidence over time had changed for cancers, the 7 most common types of cancer. And we found that there was not a change in overall cancer or 6 of the 7 most common types of cancer after kidney transplant in the last 30 years. The only change was a decrease in prostate cancer. And that's probably related to a decrease in surveillance, as there's been advice to decrease that attention. Separately, we ask questions of cancer outcomes over time, including graft failure and death with a functioning graft. And what we found, surprisingly, was that the only cancer that improved over this last 30 years was lymphoma. And there was, thankfully, an improvement in both graft failure and death with a functioning graft for lymphoma, but there was no change statistically over the last 30 years in outcomes for all 6 of the other cancers. So it suggests that despite improvements in screening and treatment for cancer in the general population, that has not been translated to improvement in outcomes in other cancers for our kidney transplant recipients besides lymphoma. So if we understand that epidemiology, I'd like to think about some of the mechanisms by which that may be the case. And normal tumor immune response involves a tumor that is sitting somewhere in the body, and the immune system continues to perform its job of circulating through, interacting with all types of cells. And antigen-presenting cells are really important for rolling around and interacting with cells, picking up antigens, and then taking up those tumor antigens and going back to the local lymph nodes or other lymph system area, whereby it interacts with T and B cells and would activate then a CD8 and a CD4 response, leading to those T cells circulating back to the tumor and resulting in a cytotoxic T lymphocyte-related response, as well as other types of immune response. With immunosuppression, as you know, that is altered so that there's a decrease in tumor surveillance, a decrease in ability to respond to oncogenic viruses and other viruses, in part because of immunosenescence, and an increase in the number of T regulatory cells and other regulatory mechanisms, all leading to a greater amount of cancer growth. If we put that in the context of our immunosuppression, much of our efforts over the last 30 years or so in transplant has been to try to prevent the T cell from managing a rejection process. And so our targets have been a lot of the same receptors that are now of interest on the opposite side for cancer. If we think about it from the transplant perspective, we have targeted targets within the T cell here in the middle, including CTLA4. And CTLA4 is an important receptor on the surface that leads to downregulation of the T cell if that is engaged. Additionally, we have targeted basiliximab as one of our induction agents, which is an IL-2 receptor, so that if we can decrease IL-2 associating with that receptor, we can downregulate activation of that T cell. And finally, the calcineurin inhibitors within the cell decrease activation throughout. If we compare those targets with current cancer immunotherapies, there's a lot of overlap, so that if we have a T cell in the top left and a tumor cell in the middle, you'll notice that when there's a T cell receptor interacting with that MHC class 1 from a tumor cell, there is an opportunity for cancer to be treated by activating a T cell against that tumor by blocking some of those downregulatory related molecules. And in this figure, PD-1 is one of the receptors on the T cell that is intended to downregulate a T cell if it interacts with PD-L1, the ligand on a tumor cell. Similarly, up in the top right, when a T cell interacts with an antigen-presenting cell, such as a dendritic cell, the CTLA4 component on a T cell would normally be downregulated if there's not a co-stimulation activation process. So that CTLA4 checkpoint inhibitor is another opportunity to downregulate that T cell in the to block that downregulation and lead to an activated T cell. Independent of the checkpoint inhibitors like those, there are other options, including CAR T cell therapies, where a T cell can be engineered to be specific towards an antigen found on a tumor, or a tumor antibody that is bispecific, so that there's one antibody that engages the tumor antigen and another that engages the T cell. Those are all in earlier forms of study. So I think that as we think about that balancing act between trying to treat a cancer and trying to maintain an allograft, there is naturally risk that we are trying to confront in ways that are as informed as possible. As an example of that, I have the opportunity to care for this gentleman. He's an 83-year-old physician with a history of hypertension, atrial fibrillation, Addison's disease, and chronic kidney disease, who was diagnosed with renal cell carcinoma back in 2010 and underwent a right nephrectomy. There was no evidence of expansion beyond the kidney, and he had done well for the next 6 years, and so we felt comfortable transplanting him in 2016. He continued to be functional and has, before COVID, been very involved in the community, including being a docent of the Seattle Museum of Flight. In 2019 May, unfortunately, he developed symptoms in his neck and back that led us to a workup and a diagnosis of recurrent metastatic renal cell involving his spine, his ilium, and his right mandible. And so from there, he needed surgery and fusion, followed by radiation. And then we discussed the risks and benefits of treating this cancer as an advanced stage cancer with the current contemporary therapy of pembrolizumab, which is a PD-1 inhibitor, meaning a checkpoint inhibitor, and axitinib, which is a VEGF inhibitor. And that would be the standard of care for general population. He was willing to take that risk because his goal was to get cured if possible. And so far, in the last 2 years, or I should say year and a half, he's done well, relatively. He's had a couple headaches with the treatments, some gout flares, and hoarseness every time he gets the axitinib. But otherwise, he's doing remarkably well. And so the questions that came back to us in transplant with all of his other care team was, should we change his immunosuppression to optimize his outcomes, both to improve his chance of response to the cancer, while also preventing rejection if we can. He had been on tacrolimus, mycophenolate at a low dose of 180 twice a day, and hydrocortisone 20 in the morning and 10 at night because of his Addison's disease. There was also a question of whether we could use any diagnostic surveillance to help in the process. And so we went ahead with using the immune checkpoint inhibitor. And I have a picture down there of James Allison and Tezuko Honjo, who won the Nobel Prize in 2018 for their work that led to the current forms of checkpoint inhibitors. Checkpoint inhibitors have actually been around since 2011. The first approval from the FDA was 2011, and you'll see here the skyrocketing approval and application of the checkpoint inhibitors for now. Over 50% of cancers in the general population are a cancer that has approval for checkpoint inhibitors. So it now is very much the first line agent for many types of cancer. As I reviewed earlier, immune checkpoint inhibitors are intended to activate a T cell against a tumor. And there's two types. There are the CTLA-4 inhibitors, and those are intended to block an interaction between an antigen-presenting cell and a T cell. And by doing so, it leads to the opportunity of co-stimulation between the CD80 and the CD28, which is the co-stimulation that would lead to activation, rather than the CTLA-4, which would lead to anergy. Once that activation is progressing against a tumor, then there's even more likelihood that the adaptive immune system will have a stronger response against that tumor. And when there's an advanced stage tumor, metastatic or otherwise, the circulating cells of that tumor then interact with T cells even more often, so that there's opportunities to use a PD-1 or a PD-L1 inhibitor to lead to greater and hopefully more specific response against the tumor because of that blockage. When a blockade happens at the PD-L1 side or PD-1 side, then the T cell can be activated because of the engagement of the T cell receptor with the MHC molecule, and sometimes even more amplified if there's a co-stimulation. Unfortunately, it's not specific, and there are many potential toxicities with these drugs. And I think we have to acknowledge that this is not a panacea. There are many elements to this that still need to be learned about, and it's not a cure. 30 to 50% of patients will see partial or full clinical remission with checkpoint inhibitors, but that definitely is not perfect. So we see toxicity across the body, with the most significant in terms of frequency and severity being in the nervous system, even Guillain-Barré or myasthenia gravis. Thyroid is common. Lung with pneumonitis or pleuritis is somewhat common, and when it happens, it's quite severe. Same with the heart with myocarditis. Nephritis is possible, less common, but definitely needs to be watched for. And of course, other areas from the skin to the joints and beyond are definitely possibly involved. These side effects, immune-related adverse effects, as they're called, can happen at any point, but typically happen within the first few weeks from initiation of treatment. They can occur later after discontinuation of the therapy, but we often see that they come on within the first 2 to 3 weeks. Interestingly, prolonged treatment with a checkpoint inhibitor does not appear to increase the cumulative incidence over time so far from what we know. For specific acute kidney injury mechanisms as we understand them now, there seems to be about 4 main categories of response in the setting of checkpoint inhibitors that lead to acute kidney injury. And most often this is an interstitial nephritis that may be exacerbated by a drug like a PPI, an NSAID, or an antibiotic that leads to an immunogenic antigen-associated response. And so those drugs are purported to, and in vivo and in vitro data, there is data to support the idea that these drugs have antigens on them that lead to an upregulation of T cells that cross over with interaction of the renal epithelial cells. In addition to that, there can be a loss of tolerance in terms of self-antigen, and that then leads to a T cell attacking the specific cell that does not have a self-antigen. Of course, there's plenty of cytokines produced in the context of this inflammation, and that is a cascade that can continue on to lead to more kidney damage. And of course, there can be off-target effects when a T cell is going after a tumor and the inflammation around that area leads to injury. Because of the concern that not only can it cause adverse effects in the general nephrology world, but also in transplant with including rejection, I've been working with a collaborative around the world, and the largest to date study that we've been able to gather data for is this most recent publication that I and Sandra participated in. And we contributed the patients from here at UW that are kidney transplant recipients treated for checkpoint inhibitors for advanced cancer. There were 69 patients over 23 institutions, and they were treated with one of the 3 types of checkpoint inhibition. We evaluated acute rejection, the time to rejection, and graft loss. And unfortunately, we found that it did correlate with the previous findings of around 40 to 50% of patients experiencing acute rejection, typically in the 3rd to 4th week after treatment starts. And of those who experienced rejection, 65% had graft loss in the following year. So it's quite significant. And because of that timing to rejection, I would suggest that if you are going to start someone on a checkpoint inhibitor for any reason, you talk with the patient about whether they would want dialysis if they experience graft injury and loss early on, and work towards access if needed. For the 2 most common types of cancer, squamous cell and melanoma, that was treated in this cohort, we found a partial or complete response in 36% of those patients treated for squamous cell and 40% of those treated for melanoma. So there's some reasonable response, and yet the risk of rejection is high enough that I think we need to continue to consider whether that's a therapy group that is worth using in our patient population, depending on the goals of care. I just wanted to highlight that there's a mix of T cell and antibody-mediated rejection in this population that we studied. So you won't always see T cell only, but oftentimes. Because of the unknowns, the many unknowns continuing with the use of checkpoint inhibitors, there's an NCI, National Cancer Institute Biorepository study that has been started, and Evan Hall here at the SCCA is the site PI for it, so that anybody, not just transplant, but anybody who experiences a grade 3 or more or worse adverse event could be enrolled in this study. And for kidney, that would mean a creatinine of 4 or higher, or 6 times greater increase in creatinine over the last month. And they would be eligible for collection of urine and blood, along with any tissue from the tumor, to evaluate it at 1 week and 1 month after registration. So feel free to consider that and reach out to Evan if you're interested. For my patient, we decided to make a conversion from Tacrolimus to Serolamis based on some data that I'll basically highlight to you in a second. The idea that we want to enable a better response by using the checkpoint inhibitor without a calcineurin inhibitor, thereby enabling the T cells to do their work against the cancer while continuing to use an mTOR inhibitor for the sake of some immunosuppression while also enabling ongoing tumor effect. With that, he's done remarkably well. His creatinine has been around 1.4 to 1.5, and I have used a donor-derived cell-free DNA test to help watch for any signs of rejection in this situation, and it's remained negative so far, and his donor-specific antibody has been negative throughout it. He's thankfully done relatively well, and his most recent PET scan in April of last year showed a decrease in the masses across a variety of areas for him. So he's doing relatively well, and I think his upcoming PET scan should be another step in that process of assessment. And so as we think about the use of these therapies, it used to be that we just talked about cancer type and stage, and then we went ahead and treated. I think there's naturally a need for us to personalize this care with more attention towards the potential of personalizing the biomarkers that can be used where appropriate across different genetic types of cancer. Understanding and then applying current treatments as we should and can, acknowledging that there are off-target effects. And so depending on a patient's health and life goals, these types of risks using a checkpoint inhibitor may be appropriate, while others may not be interested in taking that risk if there's an alternative with another type of chemotherapy or therapy in general. So when I consider immunosuppression management for cancer and transplant, it depends on the cancer. Of course, it depends on the patient's goals. Some cancers are very immunoresponsive, including lymphoma, kidney, and melanoma. And in those cases, especially if it's advanced cancer, I would likely decrease most of and stop many of, or if not all of the immunosuppression, especially at the time of starting therapy for those cancers. There may be some where we'd stop the antimetabolite, such as lung or squamous cell. And of course, this all requires conversation and work with oncology and other team members to optimize the patient's outcomes. It's a little different if there's a checkpoint inhibitor involved because of that risk of rejection. And so I have followed what data we have so far to use a mTOR inhibitor instead of a calcineurin inhibitor whenever possible, while continuing low-dose steroids in order to optimize the opportunities for a patient to retain their allograft while achieving the best cancer outcomes. I do try to come off or help the patient come off the PPI, the NSAIDs, and any antibiotics that they do not need. And so as we think about that next phase in the patient's condition, I'm going to jump forward based on time and invite your comments and thoughts about an area that I've been working on in the last year and a half since I last talked with you as a whole division. And that is that I have noticed that there continues to be the challenge of caring for these complex patients where there's a transplant program and then separately there's a cancer center. And oftentimes it's challenging to communicate across those divides, not because people mean to not communicate, but rather just because we're all busy, we all have our own way of thinking and working. And so I have been interested in forming and now have the approval to start a multidisciplinary consult clinic for organ transplant candidates and recipients who have cancer that are challenging to treat in order to address some of the questions that often come up, including when we can transplant someone after a cancer treatment, and or what optimal cancer and transplant therapies should be applied in a candidate or more often a transplant recipient in order to achieve their goals. So we're going to be starting a half-day clinic twice a month in July of this year. It will be held at the SCCA, but can be in person or telemedicine, so it enables us to really reach a population across the US with the goal of addressing these more challenging questions that an oncologist, a transplant program, a nephrologist, or someone else may have about how to best care for this patient. So after receiving the referral, we'll gather data. I will then work with our list of oncology and transplant experts to identify the most appropriate oncologist or more than one oncologist in that specific cancer area, along with the appropriate transplant experts to see the patient. We'll then gather any data after seeing the patient, meet as a tumor board representing multiple disciplines in order to coalesce and provide a comprehensive consult back to the referring provider and to the patient. And the goal with that is to address those challenging cases that really otherwise just feels too challenging to know what to do with. And so we're going to bring our best knowledge, and in so doing, learn what we can about the outcomes of our patients. With that, I've had the opportunity to achieve some funding from the Cooney Foundation to establish what would be the only active transplant and cancer bioregistry in the country. Currently, there's not a registry that's gathering data on patients who have cancer before or after transplant. And so the aim of this is to establish and lead a national collaborative bioregistry, and I do want it to be collaborative, to evaluate and enable multidisciplinary clinical, epidemiologic, and translational research. The aims that will initially be a part of this, but there will be many that can follow from it, include investigating the unknown risks and outcomes in our pre- and post-transplant patients who are treated with checkpoint inhibitors because of how contemporary and how common they are used, and with a comparative analysis to racial and ethnic minorities because we know so little about response to therapy and risks that these people have. Separately, I anticipate working with Evan Hall to evaluate the incidence and severity of transplant-specific adverse events with checkpoint inhibitors compared with the general population. In addition, I want to also address the association of social determinants of health and structural and institutional racism as it relates to cancer outcomes in our transplant recipients. And we are going to be engaging in interviews with patients and caregivers to understand their experience and the impact of cancer in that context. And I want to acknowledge a number of important collaborators in this work, including Bessie Young, Kate Butler, Evan Hall, and others here in the division and beyond who are so important in making this possible. Another aim is to lead a translational component to this where we will be analyzing molecular response to checkpoint inhibitor targets before and after treatment, and we'll be including work with the British Columbia team that has been involved in this for a while. So I anticipate this being a hub and spoke model for the registry where we will hold and host the registry here at UW, with then, as we build it out, growing it to include as many collaborating cancer centers and transplant programs who may be interested. I anticipate continuing to partner with programs across the National Comprehensive Cancer Network and across the Kidney Transplant Program Network to really maximize this. And I do truly want it to be collaborative. I expect that those who provide data will then have the opportunity to submit proposals for research. And depending on what that research is, the community engagement and overall scientific advisory team that we build will allow for a governance that will move this forward in ways to really optimize the opportunities for everybody involved. So I appreciate your attention through the last minutes. As a summary, we know that kidney transplant recipients are 2 to 4 times higher risk of cancer and death from cancer, that checkpoint inhibitors, as they currently are the most common therapy for advanced cancer, do improve cancer outcomes, but come with a notable risk of 35 to 50% rejection. I did not talk about circulating tumor DNA, but it may enable earlier recurrent cancer detection, and that's a future avenue for investigation. And I look forward to all of your comments and really feedback on how to best build out this consult clinic and the registry that I mentioned. Thank you for your time and attention. I do also want to thank patients that really make this possible, the kidney and transplant staff and division team members, including all my colleagues, including all of you. Thank you to Raj and Jonathan and Ian for supporting this work as well. And I'll stop and answer any questions.
Thanks so much, Chris, and congratulations on all this exciting work. Questions for Chris from the group, either in the chat or if you would like to actually ask a question. I will ask one, Chris. So regarding the consult clinic, could you just maybe elaborate a little bit more on what would be the types of patients that I would see as a general nephrologist who you think would be reasonable to refer to you to be seen in this kind of multidisciplinary clinic?
Thanks. I think any person where the program or the team members feel uncomfortable with making decisions about either their treatment before a possible transplant and a question of how do we get them to a transplant as safely as possible and as early as possible, or in the post-transplant setting, what do we do with the current options for treatment depending on the patient's goals in order for us to look at the options out there for them on the cancer side and the transplant side and merge those to truly optimize their goals. And I do think that it needs to be patient-centered. So one person will not be the same as the next in terms of their goals, and therefore I welcome those challenges when it comes to really addressing their goals first and then using the tools we have to meet those goals.
Others with questions, comments for Chris?
I welcome any follow-up. Feel free to email or call me. We can definitely talk more. Thank
Chris,
you so much.
When is the clinic launching?
July.
July. Okay, great. Thanks so much. And thanks everyone for being here. We'll stop here. And next week, just as a reminder, Dr. Zelnick will be speaking in the first half hour, followed by our visiting professor, Dr. Dember. So look forward to having everyone there. And I hope everyone has a good weekend.